Well, the next speaker is our old friend, more friend than old, but Rene Fortelny does not need any specific introduction.
Yeah, thank you. Thank you for the kind introduction. So it's a great pleasure to give the lecture here, and congratulations to Victor and Mr. to invite all these hernia friends and giving me the chance to be a part of it. So it's not really easy to do that. I know that we had 2 years to wait for this moment face to face again, and I appreciate it really pretty much. So these are my disclosures and no conflict of interest regarding this presentation. So I will focus in my talk on complex abdominal hernia repair. And of course, we have to look at the criteria of mesh choice in complex ventral hernia repair. Of course, we have to look if this takes place in an elective or emergency situation, if this is a primary incisional or a recurrent hernia, looking especially the risk factors. We heard a lot of things like this already, and grade of contamination, place of implementation, and of course the type of reinforcement. And I would like to start. We already had this paper of Slater, but what's the real definition of complex hernia? There are a lot of things to look at, and of course we have this consensus. This was published 2014 and relies on size and location, contamination, soft tissue conditions, patient's history, risk factors, and of course the clinical scenario, elective or emergency. If you look at the severity classes, minor, moderate, and major, we have, of course, looked especially at the moderate and severe situations, means major classes. Then you find open breast abdomen and all the different parts we already talked about. And the site of placement, of course, is already discussed. Should we rely on the best possible placement? It means the reef stopper repair in retromuscular position. Of course, we know that there are some papers, Holy Hand, looking this location and especially regarding the surgical site infection rates as well as recurrences. And number one is the sublay mesh. So coming to the point, what's about IPOM, and you see Victor Radu presented in his talk, Bye-Bye IPOM. This was 2017 in Vienna at the EHS meeting, which I hosted, and you see at the chair, Jan Kukleta, of course, and David Chen. So this was the start to have a discussion about should we use any mesh inside the cavity, and I'm very proud that we had the initial discussion in already 2017. Of course, we follow nowadays regarding the different approaches, of course, but the basic situation, we know that the best principle of mesh placement is retromuscular, retrorectus, or extraperitoneal. So, and of course, we have to look at different papers. There is one of these, the Ventral Hernia Working Group, 2010 already, and they had the grade 1 to 4 and looked at the comorbidities in grade 2. But if you look at the grade 3 and 4, they had also, based on this classification, the recommendation to use different meshes. And if you look at this grade 3, there is the permanent synthetics material generally not recommended. Potential advantages use a biological repair material, and of course in grade 3 are the same. But is this really true? Have we evidence about that? So this is my talk. So looking at this survey, this was done 2021, and you see there were included 408 surgeons from Europe, USA and other countries. Looking, the most of them did the open repair, but all as well 77% also laparoscopic repairs. And in contaminated primary hernia repair, they used synthetic and biological meshes equally. But if you look at special biological meshes or no mesh in contaminated fields, they were found in the USA and less experienced, and an increase in the number. So what is the question to be answered? When should we use permanent synthetics, absolvable synthetics, or biologicals? We have, of course, some information regarding the choice of mesh in this expert consensus. This was based on a systematic review and published by Liang, 2017. You see, there was a consensus to use synthetic meshes, but there was exception of ultralight, lightweight, or super heavyweight meshes, especially PTFA meshes for open ventral hernia repair, with the statement of increases complications compared with the medium weight mesh. So this is the recommendation to use the medium weight meshes. This was a grade B, and the so-called recommendation was grade D. Biological meshes, there is, you see, the rule still needs to be defined. So the grade D, there's almost no recommendation, and by absolvable synthetics, no data at that time. So again, a big question mark about that. So coming now to this studies we have to look at, Warren 2020, this was safety efficacy of synthetic mesh for ventral hernia repair in contaminated field. This was a retrospective study. You see the comparison between suture, biological, absorbable, and permanent meshes, synthetic meshes, and you see this results showing for the suture repairs, suture site infection rate. This was, of course, significantly less compared to the mesh placement and the mesh explantation. You look at the biological mesh, absorbable and permanent synthetics, there was no significant difference, but the recurrences, you see 10, 17, and 42 for the permanent synthetic meshes. And therefore, at the end, in the multivariate analysis, the risk for suture site infection and no effect of mesh selection. But there was the recommendation for the use of permanent synthetic meshes. So coming now to the point, the next paper by Harris, published recently in Annals of Surgery 2022, and you see recurrence rates. This was for the biological meshes almost 40%, and the synthetic meshes 21%. So this was significant, and you see the possible complication rates were similar for both mesh types. The subgroup analysis, there was increased recurrence rates in the biological group, and you see the contaminated wound conditions as well for the interaction. So again, the permanent synthetic meshes in contaminated fields could be recommended based on this study. Coming now to the recently, in August this year, published data by Dr. Hanniford. This was a retrospective study looking at biological and synthetic mesh implantation. And if we look especially at this both groups, first of all, there was in the biological group 335 patients enrolled and only 51 for the synthetic implantation. And if we look at the significant component separation technique in more than 50% in the biologic group and only 33, and look at the delayed primary closure, if you look now 45.1 means open abdomen treatment, and this was significant, and only 2% in the synthetic group. Looking especially at the mesh size, you see this was the big mesh were implanted in the synthetic group. And at the end, if we look at the bridging or inlay, almost 10% versus 2%. So this is not a good study. Sorry for that. Dr. Hanniford, you can't compare these groups, because the conclusion out of that, if we look at the results, you find here 17 versus 10%, hernia recurrences, wound complications, as well as mesh infections. And you can read in the summary, the use of synthetic versus biological meshes increased the mesh infection rate by 18.6 times. This is not a good advice to look at such papers, because at the end you could follow this recommendation to use a biological mesh in contaminated field. So, of course, you have other papers like this already showed by Franz Meyer. This is this randomized control trial looking at the synthetics versus biological mesh, and this is in favor for the synthetic meshes as in other studies as well. So coming now to, this is a review from Sabrina Tripoli. This was published 2017, and this paper, there were 11 trials enrolled. You see different biological meshes. At the end, there was poor methodological quality. The surgical wound infection rate was up to almost 23%, and the 12 months relapse rate was almost 20%. So it's not really a recommendation out of that we should use biological mesh. The other thing, and this is a paper by Huerta, Sergio, this was 2016 already. You see the FDA administration approval process to look at the biological mesh implants, and you see this in 20 studies were enrolled. There were no RCTs, and at the end, there was the statement, insufficient clinical outcome of biological measures to justify extra costs, and at the end, the statement, no indication for biological meshes. This was already 2016. So what's about now? This is the new group of meshes, the bioresorbable synthetic meshes. You know, of course, all these meshes on the market, and it started with the first study by Mike Rosen, the COBRA study, using the BioA, and you see the CDC classification 2 or 3 wounds, and mesh placement was retrorectus or intraperitoneal. And if you look at the hernia recurrence rate, 2 years follow-up, 15%, infection rate 18%. There was no removed biosynthetic mesh which was infected, and mesh placement was 90% retrorectus and only 10 intraperitoneal. Looking at the recurrence rate, if you have the subgroup group analysis, intraperitoneal mesh position was 40% and retrorectus 30%. So this was, of course, a recommendation to use this mesh only in the retrorectus position. Then we have, of course, the PHASIX mesh. This was the first big study in Europe, and we have now the 3 years follow-up data. These were published recently. And if you look at this prospective international trial, only this was a feasibility study, 84% were enrolled. You see surgical site occurrence, 26% and 13% surgical site infection rate, recurrence rate 11, and if you look at the reoperation, there was really critical ill patients, 50.5. You see all the others for the cause of the reoperation. Quality of outcome, there is no significant differences after these 2 years compared to the baseline. And they had some presence of mesh sensation in daily life. This was surprisingly 10.7%. Now looking at this review published 2020 by Amelia, 7 studies of this PHASIX mesh were enrolled. You see surgical infection rate 6.8, recurrence rate 10.4, only versus sublay 14 versus 4. Again, this is the best position you can have as well for the biological biosynthetic meshes were to recommend. You had the sublay, not only the sublay versus only, but also looking at the sublay CDC 1 versus more than 1 means in contaminated fields, potential contaminated fields, 2.7 versus 6.1. This was also interesting. And surgical site infection rate 2.7 versus 15. And if you look at the recurrences, grade 2 versus grade 3, you had 8% versus 5.1. So surgical site infection rate was not significant. Now coming at the end, the statement could be out of that we have, of course, maybe the chance to look in the long term if this is an option. And the best position in this overview shows that the retrorectus position for this phasics as well for the BioA is quite nice. Looking at the end of my talk to the EHS guidelines, recommendation grade A, you should carefully balance risk, costs, and benefits in managing contaminated ventral hernia repair, especially using biological, biosynthetic, or synthetic meshes. Laparoscopic use of biological or biosynthetic mesh implantations is only recommended in controlled trials. So take home, complex abdominal repairs in contaminated fields still challenging, and some evidence for permanent synthetics are there. But if you would like to start with biosynthetic meshes, then that might be on the one hand the most new cost-effective alternative to biological meshes, but if you use that only in studies or registries. So thank you for attention.